Today's lecture is entitled The Bones of the Lower Limb. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this presentation. If you pursue a career in orthopedics, it is likely that you will need to learn much more detail about the bones and functions of the lower limbs than I plan to cover in this lecture. As such, I want to give you an idea of the objectives that are generally listed by the American Society of Anatomy for studying the bones of the lower limbs. However, time will not allow me to cover all these objectives. Instead, I will touch briefly on the bones that make up the lower limbs and expect you to describe them at the level of detail that I will demonstrate in this lecture. Let's begin. Previously, we described the bony pelvis, the structure that serves as the intermediary between the trunk and the lower limbs. The bony pelvis consists of two hip bones and a sacrum. Each hip bone consists of three separate bones, the ilium, ischium, and pubis, that generally fuse at about age 16. The three bones meet at the acetabulum, the cup-like area visible on the external view of the hip bone, and it is where the head of the femur articulates with the hip bone to form the hip joint. Given that we do not focus on origin and insertions of muscles, we will not describe the specific points on the hip bone that serve these functions for muscles that serve to move the lower limbs. Nevertheless, there are some landmarks on the hip bone that clinicians should know in order for them to perform a physical exam. The names and locations of these structures are included in the image. Given that we discuss them in the pelvis lecture, I will not go into details here. Let's now examine an articulated hip, that is, the acetabulum with the head of the femur still inside of it, as shown on the left side of the slide. On the right, the head of a disarticulated femur is shown. Stability at the hip joint is granted by the depth of the hip socket as shown in this cross-section of the articulation between the head of the femur and the acetabulum. The hip joint is a ball and socket type of joint intended for stability and weight bearing at the expense of mobility. The acetabular labrum helps to deepen the capsule itself. The cup-shaped cavity on the hip bone exhibits a gap, the acetabular notch, in its inferior wall. In addition, a fibrous capsule attaches to the labrum, completing the integrity of the socket. Here's an image of an actual acetabulum demonstrating the acetabular labrum. The labrum is incomplete of the transverse acetabular ligament, the part of the labrum that spans the acetabular notch. The head of the femur articulates at the bottom of the acetabulum with the horseshoe-shaped lunate surface, which surrounds a central fat-filled depression, the acetabular fossa. In addition to the depth of the socket, strong ligaments on the outside of the capsule also help to provide further stability to the joint. Here, for example, the iliofemoral ligament is labeled, the ligament that extends from the ilium to the femur. The ligament at the head of the femur extends to the transverse acetabular ligament and functions mostly to resist adduction of the hip. Indeed, one way to think about the ligaments that help maintain the integrity of the hip joint is to envision a cuff extending from each part of the hip bone to the femur. These are the iliofemoral, the pubofemoral, and the ischiofemoral ligaments. Let's now move to the bone of the thigh, the femur, here shown from its anterior and posterior aspects. It is the largest bone in the body. And there are some parts of the bone that you need to know it's indicated in the slide to converse with other clinicians. Looking at the femur from the front, learn to identify the head, the neck, the shaft, and the adductor tubercle. Looking at the femur from the back, identify the greater trochanter, the lesser trochanter, the intertrochanteric crest, the linea aspera, the medial and the lateral condyles. Before moving on to the bones of the knee and leg, let's consider the blood supply of the hip joint and how it can be affected during a hip fracture. Shown in the slide are the head, neck, and proximal shaft of the femur. I specifically left out the acetabulum. The reason for this is that the acetabulum receives most of its blood supply in a retrograde direction. What does this mean? That the blood supply serving the acetabulum does not travel in a proximal to distal direction, but first travels to the thigh, then returns back towards the neck and head of the femur, and then the acetabulum. Yes, the hip joint does receive some of its blood supply in an antegrade direction via the artery of the ligamentous teres, but this is a minor contribution. The majority of the blood to the hip joint gets there from a retrograde direction via the branches flowing from the medial and lateral circumflex arteries. We will see the origin of these small vessels in a later lecture. But what are the implications for the flow of blood in this direction? Let's look again at the neck and head of the femur and take notice of what we mean when we say hip fracture. Hip fractures actually occur at the neck of the femur, not at the acetabulum. Indeed, it is rare to actually break the acetabulum. Trauma of sufficient force to break the acetabulum most likely would result in a hip dislocation, not a fracture. The location of the potential sites of fractures and how the orthopedic surgeons describe them are shown on the slide. You do not need to know these names. The fractures, surprising to most people, often occur from a catching of a foot and a twisting action of the hip in individuals suffering from osteoporosis disease, not when they hit the ground during a fall. It is the twisting action of the osteoporotic, weak bone that causes the fracture. And what are the implications for the blood supply where the fracture occurs? Here again we see the blood supply to the hip joint in two sites of fractures. What becomes clear is that the more proximal the fracture is to the head of the femur, the more likely it is that blood supply to the head will be compromised. The fracture could lead to the condition known as avascular necrosis, and the treatment for this becomes a total hip replacement, now a relatively common surgical procedure in the aged population. Let's continue now with the bones, and the next bone to describe is the patella, or kneecap. Its anterior surface is convex, but its articular surface with the distal femur is smooth. We now move to the leg, the region between the knee and the ankle, and observe two bones, the tibia and fibula. The tibia is the larger of the two, and the fibula is located laterally. Again, we could spend a lot of time describing the many parts of the two bones, but I will only mention the pertinent components here. Proximally on the tibia, there are the medial and lateral condyles for articulation of the medial and lateral condyles of the distal femur, the tibial tuberosity, and part of the tibial shaft is present subcutaneously. On the fibula, shown in the posterior view, we can notice a head and a neck. Distally, at what one calls their ankles, there is a medial malleolus that forms a prominent palpable eminence at the medial side of the ankle. The lateral malleolus is found in the fibula, forming the prominent palpable eminence of the lateral ankle. We now move to the bones of the foot A dorsal view of the foot is shown in the slide. The bone that articulates with the tibia and fibula at the ankle joint is the talus, which sits on the calcaneus that forms our heel. The talus is of particular importance to know because it is one of the bones of the body that receives retrograde blood supply. We mentioned the acetabulum earlier in this lecture, but do you remember the bone in the hand that also receives retrograde blood supply? You should look it up. Anterior to the talus and calcaneus are two bones, the navicular, so called because it resembles a ship, and the cuboid, a mostly square bone. The next row that follows are the three cuneiforms, labeled 1 to 3. Cuneiforms refer to the wedge-shaped nature of these bones. We then have the metatarsals, and note their numbering scheme, and the phalanx, called the proximal, middle, and distal phalanx for digits 2 to 5. Digit 1 only has a proximal and a distal phalanx. In a plantar view of the foot, the same bones are visible. In the medial view of the foot, the prominent medial arch of the foot can be observed, and the bones helping to form this arch are labeled. Lastly, let's consider the alignment of the bones of the lower limb. This is shown in the slide. If the bones of the lower limb are perfectly aligned, then the line of gravity should pass through the head of the femur, the patella, the tibial tuberosity, and finally the medial malleolus. Unfortunately, this is not always the case. At times, the knee joint can bulge outwards, a condition known as genu varum or bow-leggedness. Or the knee joint can bulge inwards, a condition known as genu valgum or knock-kneed. Both conditions will result in premature degeneration of the structures of the knee joint. As an aside, the condition of genu varum has been well recognized in history. Before the discovery that vitamin D was needed to maintain strong bones, the condition of rickets or bow-leggedness was not unusual in northern hemispheres. Indeed, when children are born, they are bow-legged in part due to the absence of vitamin D from absence of exposure to sunlight in the womb. Blounce, Paget's, and dwarfism can all result in genu varum with long-term consequences. I also list other causes that are less common but no less causative. Think of recent events where children were exposed to high lead levels in the drinking water. Signs in these children included genu varum. This now concludes this presentation on the bones of the lower limbs.